Melanoma Matters is an educational resource, and the opinions we express are our own and do not reflect medical advice. If you have questions specific to your own situation, please contact your own clinician. This podcast may be available in both audio and visual, so please check your platform. What more could you want?
We're good partners. Hi, everybody. Welcome to Melanoma Matters. I'm Sapna Patel.
And I'm James Larkin. Hi.
Look at this like Americana flag here, my neighbor's flag.
Yeah,
waving.
I just got Napoleon static
Yeah.
in the background with reflection.
But I have the logo over your head, so there's a Union Jack to be seen. So.
Oh, really?
Can you see it? It's like it's in your top corner, or you don't see it? Yeah, okay.
Yeah, I'm
For
not
me.
pointing at it.
I'm pointing. It's in your other corner, but cool. Cool. Okay. So today we're going to talk about Best of ASCO 2025, and we'll try. Yeah.
Do you mean Best of ASCO : 2025?
I do.
We need consistency here.
You do need to speak the punctuation always. So yes, that's what we're doing, and we're going to we're probably going to release this out of order and release this pretty soon, because one of the things we learned from a webinar or something we watched, I think you watched it, I noticed your comment was like being timely about meeting updates. So we're going to try to do that, right?
Yeah. Midsummer. Okay,
so let's do a quick fire before we get on to some abstracts that I've earmarked. So you and I have had this conversation before, but you don't know what DoorDash is, right? When I say the term.
Quick delivery service in the US, isn't it?
Yeah, it's like one of the food delivery, Grubhub, Uber Eats, DoorDash, Postmates, this kind of thing. So it's sort of become this verb, I'm going to Uber somewhere, I'm going to DoorDash something. And so you don't have DoorDash, but you have a version of it there.
Right.
It's not that like restaurants are necessarily delivering, right? It's like a third-party service or.
Yeah.
So what was the last thing you guys British version of DoorDashed?
Sushi.
Okay.
That was, when was that?
A month ago?
I think that's roughly it, yeah.
So how often are you DoorDashing?
Only really when we have guests.
Oh, okay. So but you have frequent guests actually.
Yeah, it depends a little bit on the kind of caliber of the guest, I suppose. In post.
Yeah.
Only kidding.
So I think DoorDashing is far more common in the US for families and for single people, and I think it's just a much more common. I don't think it's a once a month thing. I mean, there are times where I only do it once a month, but that may be dictated a little bit more by my travel schedule than if I was home for 30 consecutive days, I would definitely DoorDash more than once a month, I'm pretty sure.
Yeah.
So, okay.
Wow.
Cool.
If my children chose, we'd do it every day and we'd have pizza.
Right. Well, and the joke is like, a pizza is 10 or 15 bucks, but as soon as you DoorDash it, it's turned into like a $25, $30 pizza.
Right. And so you could just go up the road and pick one up, or two, or three, or.
Okay. Best of ASCO. I'm going to tell you there's 4 or 5 that I thought we could discuss, and I'll just say them now, and then you can sort of tell me if you want to discuss them. There is the Neoadjuvant adjuvant for stage 2 melanoma. So they gave a single dose of pembrolizumab. This is the UPenn study. Yorgos Karakouzis presented it. There's the adjuvant trial Relativity 098. So adjuvant Nivo-RELA versus adjuvant Nivo. There was a frontline trial of triplet checkpoint blockade, Ipi, Nivo-RELA plus sarilumab. So anti-IL-6 continuation of work from Jeff Weber's lab and group. But then, of course, there was 5-year Lifileucel update. I mean, that's the final, 5-year overall survival for Lifileucel. It does say final in the title. And I think that's probably worth discussing. So those four really, for me, I think were the tops this year. It's not to say there weren't other worthy posters or rare melanoma or non-melanoma skin things, but nothing that I would really lean to say it's changing our practice now or now we need to pivot because of that data. So those four, neoadjuvant,
Yeah,
adjuvant, frontline, and then lifileucel, second line and beyond. What do you think?
yeah. Well, I mean, just first of all, to maybe all agreed, number one. Number two, I mean, I think the adjuvant cemiplimab and SCC, that's important. We're
C
not going to
post, you're
talk
right.
about it.
You're right.
Yeah,
We'll do it. How
C,
about we do a separate podcast on it since it has a publication and everything.
yeah, and that'd be deviating a little bit outside the title of our podcast, but it wouldn't be the first time that we've done that, would it? You know, if you think
We've
about
done kidney cancer, Monty Paul and Mike Atkins. We've talked
Segramab and, you know,
Ponsegramab. Yeah.
yeah, so there's lots of examples. So I think that's important actually, and the level of benefit is really spectacular. So that's great. I mean,
Also,
actually, if we prepared for that properly, we would need to talk about the equivalent
pembrolizumab.
Pembro trial
Yeah,
630,
you read my mind.
which we chatted a little bit about in our multidisciplinary meeting last week. So I think that's quite an interesting question. We had a little bit of difference of opinion about why the results were different, and I haven't really bottomed that out. I haven't really checked, but that's an interesting question actually.
Aren't you familiar with that in kidney cancer to start?
The principle of it, yeah, I mean, that becomes quite a big discussion because people in the kidney cancer world are talking a lot about why Nevo was negative for adjuvant versus Pembro, and I can give you a talk on that. Anyway, so I thought the cemiplimab was great and simultaneous NEJM as well. But why don't we talk about the 5-year Lifileucel final? Was there a comma or not? I don't know. Because that was great that Teresa Medina, your colleague, presented the data. You sent me a picture of her
Yeah,
up on the podium. So that was fantastic. I was delighted that she presented it. And
me
for
too.
reasons of conflict of interest, I should say that I was one of the authors on that as well. So what did you make of that? Because again, I'm sort of close to that, I suppose.
Well, obviously with my bias, because she's my gal here, I thought she did a beautiful job with the presentation. Let me just say that. I thought she handled herself, I mean, with great aplomb during the Q&A because it was a little bit challenging, that part of it. And obviously this is the data that people were really interested in that cell therapy section. So really, and she just really had a good handle on the information. And I think the key is, of these, this is 153 heavily pretreated patients with advanced melanoma. They had all received prior PD-1 in some form or fashion, monotherapy or in combination. 81.7 had received prior CTLA-4, but half of those had gotten it in combination with PD-1. So only half got Ipi-Nivo, the Larkin regimen, as it were, the Larkin-Walchuk et al. Regimen. By the way, you did a very specific like bicep turn to camera here. Was this on purpose?
Yeah, I've
Looks
been
strong.
practicing all week. Do you like it?
Yeah, it looks good. It's strong.
Okay.
Yeah.
Yeah, excellent.
So,
I
okay,
haven't even flexed either. But anyway, this is resting.
bullshit. This is
No.
bull.
That would be flexing.
Okay. For the viewers, one more time. Let's do it again in slow motion.
With flexing.
There we go.
Yeah.
That's good. Okay.
I don't think people want to see that, but anyway, carry on.
They do. Trust me, they do. Okay. So, Lifileucel is, of course, now FDA approved. And so the question is, what's happening from this clinical trial data? Will we be able to see the same things in the real world? 20% of patients seem to be surviving after receiving Lifileucel in, the advanced setting. So, 20% of patients are alive at 5 years. There's a little bit of a confusion that came up during the question answer. If 20% are alive at 5 years and 31% of patients with the response rate were maintained, then that actually means that a lot of these patients who are alive are actually not complete response. The complete response rate is low. It's 5.9%. So they're partial responders. And so what do we know about what's remaining radiographically, and is it active?
Yeah.
And we just don't know. That was not part of it. But if anybody is treating these patients that were on the trial that they haven't had to go for more therapy, but technically they're a partial, it would be interesting to biopsy or resect whatever's still showing up. And then there was this comment that, the toxicities are pretty short-lived. They're around the hospitalization period. But yeah, for me, this data is really nice. Can I tell which patient in clinic is going to be one of these long-term alive at 5 years and benefiting? Yeah, I'm not sure I can, because more than 50% of my metastatic patients would get ipi-nivo. So how does that track through this study? I don't know.
Yeah, no, I think I agree with everything. And I sort of think about the early days of ipi mono. I can't help myself. And we'll talk about it, and we used to talk about it, the 20% 5-year survival from ipi
Yeah,
mono.
that's right.
And it's pretty similar.
Mm-hmm.
And I think for me, the difference maybe is, I think we now know with ipi and checkpoint inhibitors that really late tox is pretty rare. I think you see, let's just say with ipi mono for the sake of discussion, you see most of the tox you're going to see while the patients are having the treatment or shortly afterwards, bearing in mind for ipi mono it's 4 doses. You can get permanent tox, we know that, endocrine tox in particular, but late toxicity, I don't think we've really seen much of at all with checkpoint inhibitors. But by late, I mean years later. And so what I'm really saying here is, to get back to your point about cytopenias, for me, that's going to be the thing that I'm most interested in terms of late toxicities and the consequences of that, because that's what it feels like a little bit in clinic. Yes, most of the tox is front-loaded. We can understand that, but there is the odd one, and cytopenias is the best example that can persist. And if you get a severe cytopenia, that is absolutely not a trivial side effect, and can cause morbidity and mortality sometimes.
Have you ever paid attention to the lymphocytes in your ipi-nivo patients or your
I look at it.
Opdualag?
I look at it, but I've never really been able to sort of, just in clinic, as it were, by looking at it, really been able to read too much into it. But I know there's a fair amount of work on this, actually.
Since you've pulled your ipi-nivo, I'm curious if you would have a chance to look at this, let's say at baseline, and then maybe after the second or fourth induction dose, or third, if most of your patients are getting 3 or 4. Probably in the real world, we're giving closer to all 4 because we're just better at, managing and resuming after tox. But I'd be curious as to if anybody with lymphopenia at the 4th dose or right around that time actually is a responder. Because I notice it. I notice how many of our patients end up lymphopenic while getting ipi-nivo or getting checkpoint. And then what I can't say I've done is track that out to outcome.
Yeah, leave that with me.
What is that consequence of lymphopenia? So I'd love to see in your data set. I could certainly pull it from our Colorado data set. So that's one question. Then I had another question when you were talking about, what were you talking about right before? You said ipi mono, 5-year survival, 20%. There was something else you were saying in there?
Not really, just that was a benchmark, and now we're seeing, I think, another benchmark for Lifileucel of the 20% figure at 5 years in a refractory, difficult to treat group of patients. So it feels
I
a little bit.
know.
Go on.
Sorry. So you were saying that it's the 4 doses. Was ipi ever approved for you with a maintenance
No,
side to it?
no, never. We only ever had access to the 4 doses, 3 milligrams per kilogram. It's an interesting question, actually, as well, because it sort of gets a little bit into that. So you just do give the 4 doses, someone responds, then they progress later. And there was a bit of re-challenge that was allowed in the trials, and we were able to do it sometimes in clinic, certainly with private patients, not NHS. Guess what? A load of those patients will re-respond when we give more, more ipi.
We've had that conversation, and the NCCN guidelines used to talk about re-challenge if there was benefit lasting a minimum of 6 months. And benefit didn't
Yeah,
have to mean shrinkage, right? It just had to mean
no,
no
yeah,
progression. But that's exactly what I would see sometimes when I gave ipi-nivo on our uveal trial, is that you would see responses in the liver during those induction doses. Again, with the caveat, I know there's people out there, Alex, she's sorry, hi, that say, they don't get the same ipi-nivo response rate in the real world in their uveal patients. I get it, because your real world patient and a clinical trial patient are different. I mean, the clinical trial patients, just by virtue of having to be eligible, could be showing a better response than the real world. But what I would see sometimes are these responses in the liver, and then you'd get into like 4 maintenance doses of Nevo, and you've lost it. Things are growing again.
Yeah.
And then we've had the conversation about like doublet regimens. Anyway, okay. So have we said enough about Lifileucel? Continue your thoughts.
No. So, I mean, the biggest questions for me are going to be what it looks like higher up in lines of treatment, and we talked about that before. But it feels like there's going to be more efficacy, but that needs to be determined, and there's ongoing efforts to do that. And for let's say for patients who are, as things stand at the moment, refractory to ipi-nivo, BRAF wild type for the sake of argument.
Yeah.
I mean, we could go down that rabbit hole as well, couldn't we? But for me, I would want to then try and treat them with Lifileucel really as soon as I possibly could, assuming they were suitable. So that then I wonder, in that, that's the question for me in this, if you want to call it a tightly defined ipi-nivo refractory population. I'd really love to know what the efficacy looked like there, but I'm not sure we really know that actually.
So, and then just by way of background, the Iovance had data in 10 patients. It was presented at a SITC meeting a couple of years ago, I think, and I don't know that we've ever seen it published, but we've seen it presented. It's 10 melanoma patients who are checkpoint naive. And in those 10 patients, again, you'd have to meet the criteria to be treated. So there's going to be a sort of a better phenotype overall. But in those 10 patients, all 10 patients had tumor reduction. So it was 100%, clinical benefit rate with whatever short follow-up that is. So that is that sort of idea that moving it up in lines of therapy could get you a stronger response.
Yeah, I
Yeah.
guess we'll see.
Okay.
So, what was the next one?
So I mean, I had started out neoadjuvant, adjuvant, frontline, and then this advanced. But since we started this way, should we go backwards and do
Why not?
ipi-nivo, RELA plus sarilumab? Did you get to look at that? Because I know you didn't get to attend ASCO this year.
Yeah, but the bottom line was, and I think we may have anticipated this from what Jeff had shown in the past, honestly, that there was a load less tox. And this was a fairly small study, but I think the difference in grade 3 or 4 tox, you've got the numbers in front of you there, was really quite striking despite the small numbers.
You
Yes,
sound a lot
so
more, certain of it than I think any of us were certain when this was running. I don't know that we knew there was going to be a lot less tox with triplet checkpoint inhibitor. And so I think that is where people are doubtful right now. The tox went down. So Jan Maynard presented this, and it was a lovely table she has at the beginning summarizing the response rate to doublet immunotherapy as well as the toxicity to doublet immunotherapy. And then she has single monotherapy on there as well. But she also has the triplet study, Relativity 048, that was presented last summer at ASCO. And that study has a 43% grade 3/4 immune-related adverse event rate, Relativity 048, triplet checkpoint inhibitor. So 43%. And in this sarilumab, I don't think people anticipated this dropping of the grade 3/4, but it dropped to something like 12%.
yeah,
So
striking.
that is a striking reduction, 12.1% adverse event rate, and the response rate went up. So the hypothesis was so IL-6 is associated with worse outcomes in melanoma. So blocking IL-6 might actually help with outcomes, so clinical outcomes, improve response rate, but IL-6 also mediates a lot of toxicity, inflammation, so less inflammation, less side effects. And it looks like they did both of those in this non-randomized trial. So they're going to follow it up with randomized data. I think that's pretty cool. But
So
if I could say, I'm not sure we saw this marked decrease in tox in the doublet regimens when anti-IL-6 was added. And then MD Anderson also had a trial of ipi-nivo toci, and it was full dose ipi-nivo toci. And then Jeff did a flipped dose ipi-nivo toci because Jeff was really towards the end there. He was really a believer in that flipped dose ipi-nivo regimen. And so he added toci to that while the MD Anderson regimen was full dose. And then they switched to sarilumab. And for another time or for the follow-up study, a conversation about the differences in these, anti-IL-6 antibodies may be warranted because they do seem to have different effects, different outcomes.
Yeah. So yeah, I look forward to see some randomized data. Really do. I think that'd be great.
Did I just talk that whole study? Sorry about that.
Did you what?
Just take over that whole study, talk that whole study
No, no,
over.
no, no, no. It's fine. No, no,
Okay.
no. So yeah, and so then the next one going backwards would be the.
Oh, let me pause before we go. So you remember the Steve Hody work, obviously, of GM-CSF and the idea
Yeah.
that GM-CSF might mitigate um, uh, toxicity or might decrease toxicity. Pulmonary toxicity in the mouse, I think, was the big one, and then maybe some colitis. And so GM-CSF is an ECOG Akron trial that continues to this day in hopes that, we might be able to diminish toxicity. Do you remember anything about that IPI plus minus GM-CSF study and/or did you
No,
guys
it
ever
was.
try to use it in the real world?
No, we don't. There's no way that we could do that from a sort of reimbursement
Hmm.
perspective. No, I don't really. But the top line, I think, was that the tops was really again strikingly less with GM-CSF, and it's sort of that was a while ago now. I mean, I can't remember how long ago it was. Probably at least 10 years. And the story doesn't seem to have gone too much further forward, which is a shame. And I suspect not for lack of trying.
Well, I think it's because I think IPI plus GM-CSF, for anybody who still uses IPI monotherapy, they could go look up if they might want to give it with GM-CSF if you're in the States or something, because as you say, that study did sort of help us see that GM-CSF could mitigate tox. But then we moved into PD-1 where, the efficacy was better, tox was lower. But where it came back around was IPI-NIVO. And so when you showed the world this very toxic regimen, just kidding. But, then I think Steve was like, why don't we just do it with Ipi-Nivo? So,
yeah,
Steve has had this trial going for a long, long time, and it is past the halfway enrolled mark, so we might as well see it through.
yeah,
But wouldn't that be interesting if this is another way to mitigate toxicity?
yeah, fantastic.
Yeah. So,
Yeah.
okay.
So then we were back to Nevo RELA adjuvant, correct?
RELA
Negative.
098. Did you participate in that study, RELA 098?
Can't remember if we did. I don't think we put too many patients in. So I think we may have been a site, but I honestly can't remember. But sort of roundly negative, is that fair?
Yeah. What do you remember about the trial design or whatever size or anything? Nothing? You want me to do it?
No,
Okay.
no.
1,093 patients resected stage 3 to 4 melanoma, randomized 1-to-1 adjuvant Nivo RELA compared to adjuvant Nivo. The bottom line is this doublet was negative. It didn't have any superiority for disease-free survival, or what we call recurrence-free survival here, in melanoma. And so we got a press release on that many months ago, and we're seeing the data for the first time here. And so just the real top takeaway is there is no such thing as doublet checkpoint adjuvant therapy in melanoma. We've had checkpoint 915 was negative. Now we have this RELA 098 negative. So in the adjuvant setting in melanoma, checkpoint inhibitor is for monotherapy use. And it's PD-1 because we know from your trial, from the Fields trial, Checkmate 238, that Nivo is superior to IPI, but technically IPI has an indication in that space in the US as well.
Yeah. So, no doubt there'll be loads of speculation about why it was negative, just like there was loads of speculation about Checkmate 915.
Georgina did a great job in the presentation going through some of that, some of the work that the sponsor did. The sponsor looked at Relativity 047, so the frontline metastatic trial of Nivo-RELA, and looked at tumor tissue and circulating T cells and circulating LAG3 positivity compared to in the adjuvant setting here, this Relativity 098, and they found a higher proportion of circulating LAG3 positive T cells in the metastatic setting that you couldn't find in the adjuvant setting, suggesting that the presence of tumor tissue in situ actually does help generate a response to these therapies. And so it again helps us think like neoadjuvant's the right space to use this. kind of doublet, and single immune checkpoint. Metastatic is the right place. How much are we actually getting in the adjuvant setting when tumor is resected, even from our monotherapies, because we're still waiting on OS readouts?
Yeah, and you will get more toxicity. It's also worth saying an adjuvant as well, which is obviously an important consideration because, adjuvant anti-PD-1 is generally pretty well tolerated. And then, and I said this before Check 915 even read out, the one thing we knew is there'd be more tox. And you can live with more tox as long as you're getting a worthwhile upside. And I think that's the bottom line here, isn't it? So It's a shame it's negative, but important trial to do, I think.
Also, I think it shows again, we could double check this in the fact check, but I think it shows again in the Nevo RELA, you got to watch out for adrenal insufficiency. This is a side effect that does seem to happen with the addition of LAG3 at a higher rate than just Nevo alone. And again, if you're in the adjuvant setting and you make somebody adrenally insufficient, somebody who might have been cured, and
that's exactly the question. How big is the sweet spot?
Yeah, how many jelly beans in that jar?
I do find a health link clinic, and I have these conversations in kidney cancer as well, because it's obviously exactly the same thing.
Yeah.
All right,
Okay.
which then takes us to the one I'd be absolutely most interested in knowing what you think. Not that I'm not interested in knowing what you think about everything else, which was the thick primary neoadjuvant one, right?
Sure. We can also call that stage 2. Good job. Intermediate.
I don't like to sort of
Mince words. I know.
And also, hang on. You know what I think about staging and stuff, right? Because last time we had a conversation about staging, then we ended up on a 2-hour digression, if you remember.
Almost 3 hours. Rote learning. I know how you feel about rote learning. Oxford versus Cambridge. Yes. Good stories. Life is about good stories, man.
Of course. That's what we're evolved for, humans.
That's right. We're storytellers. We'll also get through this kind of quickly because I think you and I are shining now at a very similar rate, because I suspect it's really hot in your 90-degree London office without air conditioning. And it's about to hit triple digits here today. So I think we're already,
you're hotter than me.
We're at 93 right now.
Yeah, I think that beats me. I don't have a thermometer, but anyway, yeah. No. So well, so am I.
Okay.
No, but I'm genuinely interested, actually, what you think about this, because it seems kind of complicated to me, but go on.
Well, this is a study that built off sort of the UPenn regimen of single dose of neoadjuvant pembrolizumab. So they were questioned about that, but they had already really kind of shown you can get away with a single dose and you can operate and you don't have a lot of, loss of patients due to progression or toxicity.
See episode.
Yeah, fact check that.
That's my fact check, son.
Good. Do you think it's a top 10 episode, or do you think it's a?
Not top 10. I think it's mid-teens. That's what I guess. But okay, we'll fact check that.
Okay, I'm gonna guess it's.
Oh, it's become competitive.
I think it's teens too, but I'll just say first top 10 just to be a contrarian.
Let me win.
Okay, I'll let you in.
Yeah, we just made another bet earlier that you're going to win, so it's probably fair.
That's right. Okay, so this study with the single dose was for stage 2B, 2C, and it was looking at basically could you downstage in the sentinel lymph node. So there's predicted positivity rates associated with 2B and 2C, clinical 2B, 2C. If you were to take them to surgery, there's sort of historical data on what the rate of sentinel lymph node positivity would be. And so these guys gave a single dose, then took them to surgery, looked at them as one group and looked at them segregated as stage 2B, 2C to see what is my sentinel lymph node positivity after a single dose of anti-PD-1. It's a feasibility study, and I think we should say hats off to them for doing it. It was at 3 institutions. And so they said you really could do this. You could do it without surgical delay. You could do it, really without having marked disease progression or marked toxicity. And in the group of patients with stage 2C melanoma, the subgroup, the sentinel lymph node positivity rate was lower than expected based on historical controls, and but not necessarily in the 2B and not overall, but in that 2C group. So that's usually a T4B lesion. T4B, so thick, as you were saying, ulcerated primary. So that's interesting. And, they did, the median number of sentinel lymph nodes they removed were 2, and the majority of these patients that had, that these patients all went to surgery, but the majority of them stayed pathologic stage 2 with no positive lymph nodes. But in those that did have positive lymph nodes, so about a quarter of the population, the median metastasis size in the sentinel lymph node, it was 0.37 median, but it ranged from 0.1 all the way to 3.6. So it's important to know, because we often think of, this positivity. Now you've got a T4B, but you've got an N1A lesion, but that does make you 3B because of the ulceration in your primary. So feasible, single dose, did seem to have a signal of decreasing positivity rate in the subgroup that was 2C, but of course it wasn't, I don't think it was a 50-50 balance of 2B and 2C. We can fact check that. And of course they got questions. Why not the SWOG regimen? Why not 3 doses of Pembro? And it was because they had already really gotten comfortable there at UPenn with the single dose. And I don't think that's wrong. And I think, also the honest answer is we don't know how many doses of neoadjuvant you need. Is a single dose sitting on the receptor and doing the same as 3 doses, and the other doses of 3 doses are adding to tox, or are those subsequent doses actually adding to efficacy? We just don't know.
Yeah,
So we didn't see anything on pathological response in this study, which is okay. That's all I'm going to say.
Yeah, I mean, I sort of agree. I mean, I think it's a bit of a harsh criticism, sort of saying, why not more? I mean, the thing I'm most interested in would be what would be next after this study, do you think? What would you do next with these data in your hand or your computer or your PowerPoint presentation, do you think?
I think you have to randomize it. So you either randomize it and say 2B, 2C still is surgery followed by adjuvant. Do you know what I mean? Like
Yeah.
you do the sentinel lymph node up front, and you give adjuvant for the true stage 2Bs, 2Cs, or,
Yeah.
so you either randomize neoadjuvant versus adjuvant, or I think it's very reasonable for them to try to randomize the same group of patients to 1 dose versus 3 doses. I don't think there's anything wrong with trying to tease apart how much might be an optimal regimen for this group.
So just sort of thought experiment on the. I mean, honestly, I'm sort of less taken by this whole idea of how many doses actually. But let's say you tried to do a randomized trial of this. So your control arm, to be really clear, would be your thick primary, sentinel node negative, a year of adjuvant anti-PD-1 treatment, could be Nivo or Pembro, correct?
Well, the real caveat here is how many people are getting treated for clinical stage 2 versus sentinel lymph node stage 2s,
Exactly.
pathologic stage 2s, yeah. Because
Exactly.
the study already shows you a quarter of patients will have positive lymph nodes.
Well, exactly. So then, exactly. So you could kind of agree the control arm, but then the experimental arm would be neoadjuvant, right? And then you, as you say, you would be treating a load of patients there because you hadn't done the sentinel node yet, who actually weren't stage 2, they were stage 3. So then it would be a different group of patients because the control arm would, by definition, only be stage 2. So, I mean, that's what I'm wondering, how you could deal with that.
But the control arm could treat clinical stage 2s.
I always see what you mean, and sort of do the sentinel node, but
No.
sort of kind of in it.
Clinical stage 2s. So don't do a sentinel lymph node assuming that about 25% of your study has positive lymph nodes, but you can't see them. So they're not pathologically staged lymph nodes. These are clinical stage 2s. And if it's the same group that's going to get neoadjuvant therapy, the same proportion of patients theoretically would have positive sentinel lymph nodes in the control group.
Yeah, okay. So your control arm, you wouldn't do a sentinel node biopsy. You just have your clinical stage 2. So you'd understage them, right? And then you put them on a year of adjuvant anti-PD-1, right? So that would be the sort of kind of quote unquote ethical issue about not doing sentinel node.
You'd only understage a quarter of the patients, and it's already happening. If you look at NCCN guidelines do not require sentinel lymph node for clinical stage 2. It says consider it. And so what's happening, and maybe we have not had this conversation to the ground yet, but in many parts of the world and in the US, people are saying if there's already adjuvant therapy for stage 2.
No. It's happening here as well.
Yeah.
It's exactly the same conversation, but you need to deliberately not do a sentinel node, and then it would be a sort of, if you like, a simple trial design, I suppose, where, a la S1801 effectively, in terms of what you were doing, right? Neoadjuvant, you could talk about how many doses and the timing, all that sort of stuff. Yeah. And do you think that's going to happen or not, that trial?
I think they are. We can fact check this. I think the last slide probably talked about future directions. And I probably didn't even do this real justice, because they didn't just take the one dose of neoadjuvant. They did take adjuvant pembrolizumab after. It's not that it was just one dose and they, but anyway, it's nice to see. I think we've been waiting for a couple of years now to see if this was going to play out feasibly wise, and it's nice to see it. So now the question is that reduction in sentinel lymph node positivity in the 2C real? Is it a signal error here, type 1, small sample size, or is it something else? So we'll see.
Yeah. Okay. Very
cool.
Good. So that's it.
Yeah.
We're done.
Thanks for best of ASCO. No, best of 2025, ASCO.
ASCO. Got it. 39 minutes and 44 seconds.
Yeah. And we have a fact check we need to tack on. So, okay.
Good.
See ya.
Bye. Bye. Yeah.
Let me step it up for the audience a little.
I'll do my best.
Okay. Soft whisper. There you go. You can take off your shirt. That's fine.
Nothing you haven't seen.
No. Oh, well. I don't.
What?
I haven't seen it.
Sorry?
Now you're all crinkly at the tits.
Oh, sorry.
Stream.
Sorry. I apologize.
Okay. All right. Very good. So now this is a fact check for, the title of the episode.
Best of ASCO : 2025.
Yes, the way we did it last year, because we saved all of this for year end, we said best of year :
Okay,
but you're right.
Yeah,
I like it.
We're mid-year.
We are, and I don't think it makes any sense to call it best of 2025 : ASCO when we're doing it right after ASCO. So I think you're right, it's best of ASCO, but I don't know that we have a colon here.
Okay, that's for debate, isn't it?
It would look weird. Write it out. Best of ASCO : 2025.
I think it could go both ways, honestly.
Just really. To have a year on the other side of the colon?
Yeah, but it's fine not to. Maybe it's preferable not to. I don't know. I think both are acceptable as well.
Okay. How about best of ASCO 2025? No punctuation.
Yeah. Okay.
Is that okay? That. Naked of punctuation?
Yeah, I think I can live with that.
Okay. All right. I mean, I don't mean to take anything away.
Impose your views on our titles, but
it doesn't belong. Okay. So in this episode, we talked about those 4 main abstracts. Was it 4? I think it was neoadjuvant stage 2, adjuvant RELA 098, frontline with sarilumab, and then 5-year Lifileucel. And we had we did it in reverse, but we had a couple of things that came up. One was about, we didn't actually talk about this as we were prepping this, but in England, you never had approval for maintenance IPI or for re-challenge of IPI.
Correct. Okay. We never had reimbursement for that.
Okay. We were talking about IPI GM-CSF, if that was a regimen, like a fully approved regimen. And I think we remember there were several single institutions that did IPI GM-CSF. And then ultimately Steve Hody had a randomized trial. I didn't do a good job finding that citation. I'm sort of embarrassed to say. Here we go. Multi-center randomized phase 2 trial of GM-CSF plus IPI. This is E1608 versus IPI alone. E1608, Steve Hody, JCO. Is it JCO? This looks like it was just the abstract presented. Yeah, I'm doing a terrible job at finding this citation. This is all to say we know it was a randomized trial. It was an ECOG trial, 1608, where it ended up getting published. I'm failing. The point is, go ahead. Did you find it?
No. We'll have to fact check this fact check.
That's so shitty. Okay. We're not going to do that. But let's just say fell down on the job. Okay. Then we were talking about the adrenal insufficiency rate in Relativity 098. We actually had a side bet on this. I won. You claim I didn't win because I didn't make a bet, but you boldly made a bet. So if you're wrong, de facto.
Well, you didn't enter, so I'm not sure how you can, qualify either way if you haven't.
I entered by listening.
If you haven't put out. But anyway,
I put
what? Did you?
Yes, I just refrained from telling you my exact prediction.
Yeah. Anyway, so the answer, all grades adrenal insufficiency, and maybe you know the grading of adrenal insufficiency, and I certainly don't.
Trick question.
A fact check of a fact check. But it feels like it's a fairly binary side effect to me, particularly in the context of checkpoint inhibitors, because you assume if you get adrenal insufficiency, it's going to stop working altogether. And
actually, you're exactly right. I think there is no grade 1 or 2. I think it starts at grade 3 because guess what? You need replacement once it's done. There's
what I was going to say, if there were any subtle grades of this, they would just be on the way to the destination of failure. And so maybe there's some nuance there. But the bottom line is, if you get adrenal insufficiency, it's extremely likely to be irreversible, isn't it? Anyway, the answer is 6% all grades, as quoted. But they quoted a figure for grade 1 as well, didn't they? I think. But anyway, in any case, and for the record, my crazy speculation was 10%. So I was wrong by 4%. And obviously, had you entered, you would have been plus minus 3%. Goes without saying, or 2% even.
Let's just, for the listener, because this side betting is less interesting for them, I'm sure, until we say what we're betting. But let's just say that adrenal insufficiency in the adjuvant setting is no small thing. So 6% of patients, this was about 33 patients in a 543 sized cohort. I mean, that's life-changing for these patients where they potentially derive no benefit from this treatment, particularly over Nivo monotherapy, and maybe not even at all because a portion of them might have been surgically cured. So adrenal insufficiency is no small thing. You wouldn't want adrenal insufficiency. I wouldn't want it. It would change how you lift in the gym. It would change how, I get to the airport and dart in between connections so it's all to say this is one of those life-altering side effects. Doesn't matter if we call it grade 1, 2, or 3. It's life-altering because it impacts.
Yeah, I mean, I'll make a serious point as well, which is that you got adrenal insufficiency. You're on replacement doses of steroids. You get sick for whatever reason, and you don't know. Let's say you're increase it. Yeah. Because you're too sick, and then you don't have a medical alert bracelet on or whatever you guys have got. That's a life-threatening problem on the spot if the people who are looking after you don't know that you're adrenally insufficient.
And most don't. So I actually will make another point there, which is when I do have somebody diagnosed with adrenal insufficiency, once we get through okay, here's your medication, here's your emergency, intramuscular. By the way, you're going to be too sick to administer it. It's for your loved one to administer. Once we get kind of through that heaviness, at a subsequent visit, usually soon after, I bring up, we need a medical alert bracelet. This is now one of those situations where if you were found on a park bench, they're not going to instantly, they're going to think it's blood pressure and blood sugar and stroke and heart. They're not going to come to adrenal insufficiency very easily. So much better to have the bracelet. And that has happened. And we've had some post-operative patients who nobody knew they were, the surgeons or
it gets missed. Anyway, in the real world, this stuff gets missed quite frequently. That's the reality, and it's all fine. We think we know what we're doing and stuff like that, but actually, some of this stuff can be subtle, kind of out there.
And in Epic, we're working on this, but a smart set that is somebody's adrenally insufficient. Not only do they get their physiologic dosing, and let's be very careful and maybe use your endocrinologist if you don't know what physiologic dosing is. It's not 20-10 on everybody. It's not a one size fits all. Hydrocortisone. Some people need mineralocorticoid in some instances, but importantly, they need that emergency dose. They need that intramuscular. We call it Solu-Cortef here in the US. And it's nice if all of that is bundled in a smart set. So you can order the physiologic dosing, you can order the Solu-Cortef, and then maybe you can order some downstream, either testing or medical alert bracelet if it's part of the system. Anyway, that was a long time.
So I never anticipated we would have Epic tips in addition to, I mean, isn't that exciting? Oh, but yeah. So there's for those who have Epic, who are lucky enough to have Epic, there's a good tip. Right. So what were the other ones? There was one about the UPenn.
Which episode was the single
shot of Pembro? Yeah. And so obviously, no, not obviously, but unequivocally, I won this bet because it's episode 19. And I believe you said it was under 10.
I did put out for this one. I said it was potentially under 10. I knew I was going to lose, but it's because earlier in the day we had bet on something that we were pretty certain I was going to win. So I was giving you this.
Okay, fair enough. So that's episode 19 for the record. So then that ties in.
Chapel Row and I'm a Giver.
Yeah.
Do you know that song? You probably don't know that song.
No, I'm too old.
I bet it plays in the gym from time to time.
Yeah, but I try and block everything out. Unless it's like 80s indie music, which isn't very common. Anyway, like the wedding present.
Yeah.
Which never gets played at the gym. But there we are. It's digression.
I think
we should blame the coaches, actually. I think.
They might be too young. You might not know.
No, they won't. They are too young.
Yeah.
Too young. They're too young. They're missing out.
Yeah.
Anyway, next thing.
Future directions of the neoadjuvant stage 2 abstract. So we were thinking maybe Yorgos mentioned if they were doing a follow-up trial. The slides actually mention that a randomized trial is warranted. It's justified, but it's unclear if they're following that up. And in the episode, we talk about like what we thought a trial could look like. I think that's it for best of ASCO 2025. No punctuation. Yeah. Undressed.
Still managed to do 11 minutes of mainly digressions and sidebars.
Yeah. We're pretty famous for that.
Famous is a strong word.
Oh, okay. That's our MO. That's our modus operandi. To prepare. We're really good preparers. And then we flounder a bit when it comes to like focus. In this, only in this. In the gym, I think you're an excellent coach, preparer.
That's kind. Too kind, I would say.
Is it?
Yeah. And you prepare much better than I do, I know that. You're meticulous. Yeah, you are. No, you are. Okay. That's a compliment.
Okay. Great.
Right.
Thanks.
We're good.
Okay. Thanks for this. See ya.
Bye.